Okay, so we'll get started. My name's Charley Pick and I am Tissue Viability Nurse Advisor for Coloplast. And I'm really excited for you to join us on the first of our Prepare to Heal webinars. Today we're going to start by looking at wound assessment, and there will be a repeat of this webinar later on in the month. And then in February we will look at wound preparation, and then in March we will look at treatment. So as we go through today, I have got my colleagues Janice Bianchi and Ellen Buckley online. If you've got any questions, please feel free to put them in the chat and they will answer them as we go through. Okay. So here at Coloplast, we've got a three-step approach to simplifying wound management. We need to try and make wound management simple. It can be a very complex thing. But if we remember these 3 steps, this will help. So we're going to look today at assessment. We need to do a really robust assessment, holistic assessment of our whole patient to make sure that we know what is going on with them, what is going on with their other conditions, and how we can best manage that wound. Once we've done a really robust assessment, we can then move on to step 2, which is about preparing the wound. And wound preparation is key to create that optimum healing environment. Once we've done step 2, we can then move forward to step 3, and this is about how we manage our wound, what type of dressings we use. And if we continue this wound management and the simplification of this wound management, we can move that wound forwards to healing. So wound assessment, why do we need to do wound assessment? So the learning objectives for today are we're going to look at the importance of undertaking a detailed patient history and examination, why we need to do that. It will help us to identify any barriers to healing using the triangle of wound assessment. And then we will discuss about accurately documenting wound assessment data and why it's really important that we do document what we have done. So the aims of our wound assessment are to identify what the cause of that skin breakdown is. Are there underlying causes that are causing that wound? And are there any identified risk factors that are stopping that wound from healing? If we are able to identify underlying risk factors and correct or treat them, then we can help move that wound towards healing. The aims are also to identify appropriate wound management options, make sure that we are giving the patient the best treatment at the right time, and we can help control any wound-related symptoms. So whether that wound has lots of exudate coming from it, if that wound is particularly painful for that patient. This will also help us to prevent any further skin breakdown, and we can discuss with the patient what their expectations are. Are they expecting us to heal that wound, or is their expectation that we are managing the exudate for them? It will also help us to provide support and patient independence. So the outcomes of wound assessment, if you do a really good, robust wound assessment, then that can help us to improve our clinical decision making. It will help make the clinical outcomes far more achievable, but it will also improve your cost effectiveness. If you've done a really robust assessment of that wound and you've prepared that wound really well, and then you make the right decision when you are deciding what management to use for that wound, then the likelihood is that we can reduce the risk of complications. And with complications come further costs. So if your wound gets a wound infection, or the patient's wound gets infected, then you're going to have to use antimicrobial treatments, you may have to use antibiotics, and that pushes that cost up. It also helps you identify what your patient's expectations are. So as I said previously, is the patient's expectation that you will heal that wound, or are they expecting you to manage the problems that they are finding with that wound? And it helps doing a really good assessment to facilitate better communication with your patients. And if you talk to patients throughout their assessment, throughout their wound preparation, and throughout their treatment, they're going to be more likely to comply, but they are also going to be more realistic in what the outcomes of that wound is. So a frequency of wound assessment will depend on the condition of the patient and the condition of that wound and what care setting they're being looked after in. But you also must make sure that you follow your own policies around wound assessment and how often that should be done. As a minimum, holistic wound assessment should be done every 2 weeks in an acute setting and every 4 weeks within a primary care and community setting. But you will reassess that wound every time you look at it, and you may decide that that wound is deteriorating, and do you need to relook at your holistic assessment to find out why that wound is deteriorating. So if we don't do a full assessment, if we don't look at our patients holistically and we don't do that full wound assessment, this can lead to an inability to identify factors that can delay healing. With that comes your inappropriate management choice. So if we're not choosing the right dressings and right treatment and management for that patient, we could cause problems with that wound. It may be that we're not managing the exudate properly, and therefore the surrounding skin is becoming macerated. And if that surrounding skin that is macerated is not then dealt with, we could end up making that wound bigger than it initially was. There could be a development of complications such as infection. And then, of course, if we have infection, as we've previously said, this could increase the costs and can delay healing. So we need to make sure that the assessment that we're doing is robust in order to devise the most appropriate management plan for that patient and for their wound. So wound assessment, it can be challenging. There's an awful lot that you have to think about. So when you're doing your holistic assessment, you need to think about your patient as a whole and not just the wound, the whole in that patient. So you need to look at your patient factors. What's their past medical history and their comorbidities, and are they being well managed? Have they got any immune deficiencies, or is there any medication that they are taking that can cause immune deficiencies? Does that patient suffer with pain, and is that pain causing problems for them elsewhere in their life? Is it mean that they're isolating themselves because perhaps their wound is quite smelly, or their wound is very wet and leaking all the time, and they're having to think about how often they're changing their clothes or how often their dressings are being changed? And if the patients don't understand why we're doing what we're doing, this could lead to poor compliance. They may not be happy to go with the treatment or the management that we are suggesting. You also need to look at your organisational factors, and this could include a lack of consensus and no standardisation of accepted practice. There is a deficit in wound care education, and often this education is given to us by our colleagues, by long-standing ritualistic practice, but it could also be within organisational factors that there's an ineffective team working. Often with wound care, nurses have a particular preference for which dressings they prefer, which dressings they've had better outcomes with. And so if that patient is seeing a number of different nurses, each one may put on a different dressing to manage that wound, but actually we aren't then managing it because we're changing the treatment all of the time. We look at educational factors, look at traditional knowledge and ritualistic practice, and that comes from a lack of education in wound care. There are often quite negative attitudes towards wound care. So we, as wound care nurses and specialists, don't have that backing like you do with diabetes and obesity and having that consultant-led team. We're a nurse-led team, and often our voices aren't always heard. So there can be a negative attitude towards wound care. And of course, the inappropriate training, or I would say maybe not inappropriate training, but a lack of training and support within the wound care field. And then, of course, we've got to look at our wound. Now, some people will say that looking at the wound is the most important part, but you need to look at all of these factors. They are all important and each go hand in hand with each other. So with your wound, you're going to be looking at things like the depth and size of that wound and the location. Whereabouts is it on the body and what is causing it? Is this wound in an acute phase, or have we got a chronic wound that we're dealing with? Is there any bacterial burden or biofilm buildup in that wound? And looking at things like oedema and exudate, how much exudate is coming from that wound? Is that wound really dry, or is it really wet and that's causing further problems for the patient? Is it damaging the skin, and what's the barrier function of that skin like now? Do we need to look at the pH levels of the skin and how we can bring the pH back down to where we need it to be? So to be able to do our wound assessment, there are numerous frameworks out there. So in the year 2000, we had wound bed preparation, which solely looked at the wound bed. And then in 2002, we moved on to time, which is the tissue, infection and inflammation, moisture, and the edge of the wound. So it brought that edge in. And then in 2015, as here at Coloplast, devised the triangle of wound assessment, whereby we look at the wound bed edge, and the peri-wound skin, and we incorporate all of those elements into a simplistic tool to help us manage that wound. So the triangle of wound assessment is a holistic assessment framework, and it helps us to assess and manages all areas of the wound. So we look at the whole patient first. So we're looking at that patient holistically, looking at their comorbidities, finding out how well they are managed. Are we managing any underlying causes? We then look at other factors such as socioeconomic factors. So how these patients live their lifestyles. Are they working? Do they live in a good home with good support, or are these patients homeless? And how are we going to manage that if that is the case? And then we look at the wound, and then we divide that wound into 3 areas. So first and foremost, we'll look at the wound bed and what's happening with that wound bed. And then we will look at the wound edge and include the peri-wound skin finally. And by doing this full assessment, this will help us with making clinical decisions that are good for that patient at the right time, and making sure that our management plan is the best one for that patient to manage that wound and move that wound towards the healing process. So how do we assess the wound using the triangle of wound assessment? So as I've said, we look at the three areas of the wound bed, the wound edge, and the peri-wound skin. And we're going to go into a little bit more detail on each of these. But first, you need to gather information through patient assessment. So you need to have conversations with your patient. You need to do a full holistic assessment. And to do this effectively, it's really important that you gather all the information about that patient. You don't want to just know about the wound and how long they have had that wound. You want to know about their past medical history. You want to know if they've had any wounds before. You need to know what medication they're taking. And only after that should you then start examining the patient and looking, touching, and smelling. Smelling is really important also because it helps us with that diagnosis of the wound. So first and foremost, you need to listen. You need to have a conversation with your patient and listen to what they are saying to you. So you can take a general medical history from them to identify any factors that may be delaying that healing process, that anything that the patients have got concerns about. So have they got diabetes? Has that patient, are they well controlled with their diabetes? And have they got support with that diabetes? If their diabetes isn't well controlled, we know that we can run into problems with any wounds that patient might have. But this is also your time to build a rapport and your trust with that patient. Be open and honest with them about what it is that you're trying to do and why you're trying to do that. You need to look at their medications, record what medications they're taking, and find out, have these been increased recently, or even has the dose been lowered, or have they been stopped completely? Have they been started on a new medication, and how is that affecting that patient? Is it helping with the symptoms, or has it made things worse? And you also need to look at compliance with their medication. Are they taking it regularly? For example, analgesia. If your patient has been prescribed regular paracetamol, let's say, are they taking it regularly, or are they waiting for that pain to come before they take that analgesia? And if that is the case, we need to have discussion with them about why it's important to keep on top of that pain. Once you've done the listening aspect of your assessment, we can move on to looking. So we're going to look at the age of our patient. Are they old or elderly? Are they young? What's their body weight like? Are they nourished? Are they well nourished? Or are they undernourished? Are they not getting enough? How's their mobility? Are they able to mobilise? Or is this patient wheelchair bound or even bed bound? And how are they being assisted to move within that? What's their general demeanour like? Are they very anxious? Are they particularly tired? Are they not sleeping? Or is there some confusion there? You need to look at their clinical observations, their blood pressure, their heart rate, their saturations, because this can help with your overall assessment of that patient. You need to look at their illness status. Are they generally well when they're coming in to see you? Or are there some red flags there that you are thinking there might be something else going on with this patient? And you need to look at your previous dressing. Find out what previous dressings have been used, what that dressing looks like when you remove it, because that can tell you a lot about what's going on with that wound. You need to do a top-to-toe skin assessment. This will help you to confirm or reject what you're thinking your diagnosis might be and what then your treatment plan may be moving forward. So things that you need to look out for when you do a top-to-toe skin assessment will be how dry that skin is. And is that skin dry in a particular area, or is it that skin dryness covering a whole limb? Or on the flip side of that, is that wound or the surrounding tissue very wet? Is it macerated? And what's causing that maceration? You need to think about things like incontinence. For those of you that have looked after leg ulcers and bilateral leg ulcers, I'm sure many of you have seen bandages that are covered in urine from incontinence. So you need to have conversations with your patients about their incontinence, whether they are aware that they're being incontinent and whether they need help with managing that incontinence. You need to check to find out whether pulses are present. So particularly in our diabetic patients, you need to find out whether they've got any pulses present. But with our patients that also have a vascular compromise, we need to know how compromised they are, whether they've been seen by vascular already, or whether that's something that we may need to do a referral into that service. You need to find out about their pain, whether they're in pain all of the time, or whether they are only in pain if when that wound is the dressing is being changed, or whether it's positional. Do the patients go to bed in a chair, or are these patients sitting in a chair with their legs down, or are they in a bed overnight? You need to have a feel for temperature and look for any inflammation or what you may feel is infection that is present there. Is there any non-blanching erythema? So your patients that you may be thinking have a pressure ulcer, is that surrounding erythema blanchable, or is it not? Is there any ischemia? Does that limb feel cold to touch? Is it dusky in colour? And then you need to think about your skin sensitivities, whether there's any numbness there, whether there is any burning or tingling at the site of the wound or in that limb. And then we move on to odour. So another one of our senses. We've looked, and now we're going to use our smell. And odour can be really undervalued during a skin assessment, but it can provide us with an awful lot of information about that skin condition. But you've got to be sensitive about it. If you're taking down dressings and you know that there's going to be an odour, you need to think about your facial expressions and how you deal with that odour. Odour is going to be very embarrassing for your patient, and they will probably already be embarrassed when they come into you. They will probably tell you, I'm really sorry, nurse, but this wound is really smelling. And the trouble with odour can be that these patients will then socially isolate because they don't want to go to the shops or they don't want to socialise with their friends because they're worried about other people being able to smell that wound. So odour can reveal several things, which include poor personal hygiene. So this goes back to your socioeconomic factors and how that patient is living their lifestyle. It can help with incontinence. So is it urine, feces, or both that the patient is struggling with? What that wound exudate is like, and whether you feel that there's any wound infection there. And sloughy and necrotic tissue can cause an odour. But something that you also need to keep an eye out for is malignancy. And if something with that wound really doesn't look right and is not healing, then there may be the need to refer these patients on for further investigation. So your wound bed assessment, this is where we're going to look at what tissue type we have. So we're going to go into each of these subject areas a little bit more in depth. So necrotic tissue, I'm sure probably a lot of you have already seen necrotic tissue, but this tissue can either be very soft and wet, almost boggy, but it can also be very hard and dry. So if you think about your patients with diabetes that may have a diabetic foot ulcer, often these can be covered with that very hard and dry eschar, there's no necrosis. It can be very black, or it can be quite dark brown in appearance. And what it is dead tissue. It contains dead cells and any debris that the wound is collecting on the surface of that wound. It can point you in the direction of poor tissue perfusion. If that wound isn't getting the blood supply that it needs, the tissues are going to die off and necrosis will occur. But we know that we need to get rid of that necrotic tissue because necrotic tissue delays wound healing. And we need to be able to remove that carefully. And that's where your wound management plan will come in. Sloughy tissue. So this tissue can vary in colour, but generally tends to be yellow, can be slightly grey green in colour sometimes. And this tissue is quite fibrous, can be full of pus, and also contains dead cells. And what happens is the neutrophils in the wound, they get exhausted and they die off. And then this can be seen as a creamy white film on the surface of the wound. Now, slough typically collects in the deeper areas of the wound and can be quite tricky to remove. But it can also indicate that there may be a rise in bioburden there. There may be some biofilm, or there may be an infection brewing. Again, slough buildup is detrimental to that wound healing. It's not an optimal wound healing environment when there is slough or necrotic tissue there. And we need to make sure that we can remove this to be able to move that wound forward, to move it into that healing phase. So granulation tissue, now this is what we want to see in the bottom of our wounds. We want to see that nice pink or red new connective tissue that's building a new blood supply. And this is when we know that we're in a good stage of our wound healing. Now, granulation typically grows from the base of a wound up, and it will fill wounds of all sorts of sizes. It can be the smallest of wounds and it can be the largest of wounds, but this is the tissue that we want. The thing with granulation tissue is it can be dusky, dark, purple sometimes in colour, and this is when you know that you've got a problem. It could result in an infection brewing, but it could also mean that you've got some vascular compromise going on there and the tissue perfusion isn't great. If the granulation tissue is quite friable and it bleeds easily, this may indicate local infection, especially if the patient is complaining that their wound is becoming increasingly more painful. And then you have the epithelialization of tissue. Now, this is what we want to happen. This is when we are moving forward with that healing process. So epithelialization are pink, sometimes white tissue seen in the final stages of healing. And you often see this start around your wound edges. It's that light pink tissue. And what it means is the epithelialization cells are starting to migrate across that wound bed. Sometimes you can get little islands of epithelial cells, and we don't want to disrupt those. Often people will think that this perhaps is slough forming. You need to make sure that you're assessing that wound bed properly to know what it is that you're looking at. This is where also at this stage we need to make sure we are giving that patient and that wound that optimum healing environment. We need to make sure that our wound is nice and moist to be able to let those cells migrate across that wound bed with ease, really. And we need to make sure that the wound management that we provide for that patient, so our dressings, promote that wound environment and enhance the healing. So your wound bed assessment, you're looking at your wound exudate. So you need to be looking at the volume of your exudate. Have you got a lot of exudate there, or is this wound bed really dry? And if it is dry, why is that? If you've got copious amounts of exudate coming from that wound, why is that? Is it because the wound is infected, or is there something else going on there? Is there an awful lot of edema for that patient on that surrounding tissue or in that lower limb? You need to look at its consistency. Is the exudate really thick? Is it pussy? Or is it really thin and watery? And that ties hand in hand with the colour of your exudate. Is it clear? If it's clear and watery, we quite like that. Is it cloudy and purulent and very thick? That's something that we're not so keen on. So you can have blood-stained exudate. You can have your serous exudate, which is your straw colour, pale yellow, which is part of the inflammatory phase, or you can have purulent, pussy, thick exudate, which probably indicates that you've got some sort of infection, and this is green, grey or yellow in colour. Now, as your wound progresses through the healing stages, the exudate levels should reduce, and that indicates that the wound is progressing towards healing. So that's where we want to be. You need to be looking at infection, whether there's any local infection. So this is your things like increased pain, the erythema surrounding that wound edge and the peri-wound skin, whether there's any edema to that surrounding skin. Is it warm or hot to touch? Is there any increase in the exudate levels? And how is that exudate? What does it look like? How thick is it? What is the volume of it like? Has this wound all of a sudden it's not moving towards that healing phase? Has it just become static? Have we delayed that wound healing? Is there any odour there? And does the granulation tissue bleed really easy? Is it friable? But then you also need to look at your spreading or your systemic infections. So is there any increased erythema, or is there any spreading erythema? Is that redness spreading across that limb or up that limb? Has the patient developed a temperature? Can you see any abscess formation? And is that wound starting to break down? Have you got any cellulitis to particularly lower limbs? But we can get cellulitis anywhere. But you will have seen, I'm sure, cellulitis in lower limbs. How is the patient feeling? Do they feel generally unwell? Do they feel like they have flu-like symptoms? Are they really achy? And have we done any bloods? Is there any raised blood count levels there? So to summarise wound bed assessment, we as clinicians should be noticing what the tissue type is like on that wound, and we should be able to describe what we are seeing. We should be able to describe what the exudate looks like, how much of the exudate is there, and what colour is it? What's the thickness of it? We need to be able to see if there are any signs of infection, and we need to be able to identify what those signs of infection are, and whether we are at a local stage of infection with this patient and their wound, or whether this infection is now moving into systemic infection. We need to monitor the depth of the wound, whether this wound is getting any deeper, or whether it is healing, and what structures are visible. So can you see any bone? Have you got a category 4 pressure ulcer where bone is visible? Or have you got a wound on the lower limb where you can see tendon visible? Okay. And then we move on. Once we've done a really robust wound assessment of the wound bed, we're going to move on to the wound edge, and we're going to look at these things in a little more depth. So you need to be looking at the edges of your wound. Is there any maceration to that wound? This is this white tissue that's surrounding on the wound edge of this wound here. And what it is it's waterlogged tissue. So it's repeatedly got wet, and it basically can't protect itself anymore, so it gets waterlogged. And this indicates that there isn't an optimal healing environment. Actually, what's there is a suboptimal healing environment with the exudate management, and likely is that we're not managing that exudate appropriately with the wound management plan that we've already got in place. And maceration can delay wound healing. It can lead to fungal and bacterial wound skin infections, but it can also be very painful for the patient. Wound maceration can be painful. You will often find wound maceration around moisture lesions, and these can be very painful for the patient. But not only that, if we have got damaged skin, that's what macerated tissue is, it's damaged. If we don't do something to right that wrong, then the likelihood is that this wound could increase in size, and that's not what we want to do. Dehydration. So is your wound and your wound edges, are they dry, and why are they dry? And the reason for a dry or dehydrated wound edge is because there isn't that exudate production to keep it nice and moist. So what we need to do is rehydrate the wound edges so that the epithelialization tissue can start to migrate across that wound bed, and we can start moving towards the healing of that wound. And that's why if we don't reintroduce moisture to this wound, it slows down that division and migration of the epidermal cells. And then we won't get that wound to knit together. We won't get that wound to heal. Undermining. So you can get undermining at your wound edges. You may have seen this with some of your pressure ulcers, certainly category 3, category 4, your deeper pressure ulcers. And undermining at the wound edge may indicate that this wound is in a chronic stage. And often there is tissue loss, usually associated with larger non-healing wounds in patients. And that's why I use the example of pressure ulcers for undermining. So what undermining is the wound on the outside may be, from what you can see, 2 centimetres by 2 centimetres in width and length. But actually, if you probe underneath that wound, it could expand to maybe 4 or 5 centimetres, going further under those tissues. So that's what we mean by undermining, that the underside of that tissue isn't there anymore. And then we have rolled edges. So rolled edges you tend to get in deeper and larger wounds, and the edges become thicker and they roll. They're very difficult to heal, and quite often these patients may need a surgical intervention to remove that rolled edge, to give us a chance to get this patient to move towards wound healing, to allow the epithelialization to occur at the edge of the wound and to migrate across there. But also rolled edges can be an indication of malignancy. And if you are suspecting that there is some malignancy in that wound, you do need to make sure that you make that appropriate referral to the appropriate service. So to summarise wound edge assessment, clinicians need to be noticing what tissue is present at that wound edge. Is there any macerated tissue? Are those wound edges really dry, and how do we overcome that? Is there any undermining of that wound? And if so, how deep is that undermining, and whereabouts is it? A good to document your undermining is to use a clock face. So if you've got let's say a category 4 pressure ulcer on the sacrum, so 12 o'clock is going to be towards the patient's head, 6 o'clock is going to be towards the patient's feet. And if you write whereabouts on that clock face your undermining is, it's easier for the next person that's then coming in to have a look at that wound. They can see if it's still as deep at that place, at that position on that clock face, or whether there is now undermining elsewhere on that wound. And are there any signs that may require further investigations? Are there any rolled edges at your wound edge? Or are you concerned about any malignancy? So the periwound skin assessment, we're going to go into that in a little more depth. So again, we can have macerated tissue, and macerated tissue can not only be at the wound edge, but it can be on that periwound skin, and can often be because we're not managing that exudate appropriately. So the dressings or the bandages that we're using to try and manage that exudate can make it worse, because they can trap that fluid against the surface of the skin and damage that tissue. We can get excoriated tissue surrounding that wound in the periwound skin. And what excoriation is caused by is a repeated injury to the surface of the skin. So you may well have seen this with a patient that has maybe reacted to a dressing, and it causes this, you can see where the dressing has been, and it causes that excoriation. So what we need to do here is because with excoriated tissue, it can become very itchy, and we need to break that itch-scratch cycle. We need to improve that barrier function and reduce the inflammation that is there. And to be able to do this, you can use an emollient. It can help with that itch-scratch cycle. If we can stop the patient from scratching, we can stop the patient from breaking their skin, and then it's more difficult for infection to be introduced to that wound. So dry, scaly skin. Now, I'm sure everybody has seen leg dressings when we remove those bandages and that big cloud of dry skin that comes off. And so this dry skin is caused by the keratin cells. They become very flat and scaly, and the skin can feel very rough, can be very flaky, but can also be very itchy for that patient. And again, we can get stuck in that itch scratch cycle. So when the skin is really dry, the function of the acid mantle, it doesn't work properly. It reduces, and then we don't have that protection against the bacteria that we need, and that we need our skin to protect us against. So that with minor trauma from scratching will increase our risk of infection, because we've broken our barrier, and our barrier is not doing the job that it's there to do. Hyperkeratosis, so this is a term that is used to describe excessive buildup of dry skin, often found on lower limbs. You can find it on hands, heels, and also the soles of feet. And you can get this formation around wound edges, particularly in patients with diabetic foot ulcers, and it can impede that wound healing. We need our surrounding tissues to be nice and healthy to give our wound the best chance of healing. Callus formation, so this is what it says it is on the tin. It is a callus, a build-up of thick, dry, hard tissue at the wound edges, and often you will find callus formation on diabetic foot ulcers. It's a real thickened and hardened part of the skin, or around the soft tissues, and especially in an area that's been subjected to friction or pressure. So often we find callus on the feet from really ill-fitting shoes, and it's caused by pressure on that wound, and that's why we often see it in diabetic foot ulcers. They don't have the often patients with diabetic foot ulcers don't have the feeling that everybody else does in their extremities, and often can be stood on something for a long period of time without realizing it, causing injury to the tissues in their feet. And then we have eczema, or a dermatitis, which is an inflammation of the skin. Again, can be very itchy, can be very, very red. If the patient is in that itch scratch cycle, the eczema can weep and can cause a crusting. We're not really sure on the cause of eczema, but one of the possibilities is a dysfunctional interplay between the immune system and the skin. So they're not talking together properly. There's an issue between the immune system and the skin. And often we can find in patients, certainly with lower leg wounds, you can get a varicose eczema. which is related to the venous insufficiency and often venous leg ulcers. So to sum up on the peri-wound skin assessment, as clinicians, we should be noticing the overall condition of that surrounding skin. What's going on with that surrounding skin? Is it very dry, or is it very wet because we haven't managed that exudate appropriately? Are our patients stuck in an itch scratch cycle, and how can we stop that from occurring? Are non-healing wounds displaying deeper, dry wound margins? And are they surrounded by that edema? Is the skin really inflamed and maybe broken and really painful to touch? So you need to document what you're seeing, what is going on around that wound. So these are questions that can help you when you are doing a wound assessment to confirm the cause of a wound. So how long has that wound been there? Is this wound quite an acute wound? Has this only been going on for a few days? Or has this patient had this wound for 6 months, a year, 2 years, 20 years? How long has that wound been there for? And what is the nature of the wound? Whereabouts is it? What's the location of it? What do you think could be the cause of that wound? If it's a lower limb, could it be vascular compromise that's causing it? Is it a pressure ulcer? Is it pressure that's causing it? Or is it somebody's underlying condition that is causing this wound? And what is the amount and the consistency of your exudate? Asking yourself all of these questions when you're going through this wound assessment can help you to confirm what is the cause of this wound. And if we've got a cause of that wound, that will help with our management plan moving forwards. So some of the further investigations that you can do to aid your diagnosis. So we can do a blood screen looking at a full blood count, use an ease, looking at a random blood sugar screen. And if you're concerned about this possible infection or systemic infection for this patient, you may want to do an ESR and a CRP. And what this will determine is this patient anemic? Are they suffering with hyperglycemia? And is there any systemic infection there? Now, wound swab, you need to make sure you follow your policy and protocol because this will be different everywhere. But you can swab your wounds if you've got a non-healing wound that is exhibiting clinical signs of infection and local infection. And what that will determine is whether there is a wound infection there. For your leg ulcers, you can look at doing your ABPI, your ankle brachial pressure index, and that will help you to determine if there's arterial perfusion to the lower limb. Have you got any arterial or vascular compromise in that limb? And from that, do we then need to refer this patient on to the vascular team? But you can also do your pressure perception. So patients with diabetic foot ulceration, you need to see how they can, what their feeling is like and whether they've got pulses, how warm their foot is, what that foot is looking like, as in what colour is it? Is it looking dusky? So all of these investigations can also help you aid your diagnosis along with the questions on the previous slide. And then documentation. So documentation is really, really important in every aspect of our nursing. We need to make sure we adequately and factually document what we have done for that patient. So you need to make sure that your documentation is factual. You need to write what you've done, why you've done it, make sure it's relevant, make sure that it's accurate to what. So make sure you've got the right patient that you're talking about and what you have actually done for that patient. But you need to write also your relevant positives and your relevant negatives. So a relevant negative could be a patient that has got an ulcer on a foot, but actually that patient doesn't have diabetes. So that is a relative negative. And it's really important that we know actually this patient doesn't have diabetes. So that might not be the cause of why that patient has got an ulceration on the foot. So then we can look at other reasons as to why that ulceration is there. You need to make sure that you write your documentation as soon as possible after the event because it's fresh, you know what you've done, it's current in your head, and you can remember what the condition of that patient was, what the condition of that wound was, and you can give a more robust reflection of what you've done. You need to clearly write and make sure that you're, if you are still handwriting, make sure that your writing is legible and that the next person coming towards that knows what you have done and how they can continue that care plan, and make sure you date, time and sign, again with a legible signature alongside every entry that you do. I'm sure a lot of you now are probably doing documentation via iPads or laptops, certainly out in the community and primary care. So that makes the legible writing much easier because it's typed, but you still need to make sure that you follow this process, make sure it's factual and relevant, and make sure you do it as soon as you have completed that activity. And then you need to confirm the action plan with your patient, but hopefully throughout all of this, throughout the holistic assessment and the wound assessment, you're talking to your patient anyway. You're telling them what you're seeing and how you're going to move that management plan forward, what you think is causing that. And if you have this open dialogue throughout with your patient, they understand what's going on throughout that whole assessment. It's not just a shock to them at the end, oh, this is now the treatment plan that we're going to do, and they don't understand the reasoning for that. So have that open communication with your patient throughout. And your action plan for the patient should explain what you're going to do and why you're going to do that, whether or not they need to forward to have any further investigations, or whether you need to do referrals onto specialists. So whether you feel that that patient may need to be seen by the tissue viability nurse, or whether you have got a leg ulcer clinic in your area that you can refer that patient onto. And you need to discuss whether the patient is appropriate for shared or self-care, and also plan for their discharge. Now, don't promise this patient that you can heal them within 6 weeks. You have to be open and honest about wounds, and that we can't put a number on how quickly we can heal that wound. But what we can say is that we're going to do everything that we can possible to move that wound into the healing phase and assist that wound with wound healing. Okay. So with your supported shared care or self-care, depending on which terminology you use, we need to try and encourage our patients that we deem that would be able to do shared care or supported self-care. They should be encouraged to be involved with their care. And if they're able to do so, can we share doing that wound care? You know, do they need to come and see you 2 or 3 times a week if you're in a GP surgery? Or could that patient actually be doing some of the dressing changes themselves? And if they can't do it themselves, have they got anybody at home that may be able to facilitate that? Have they got family or a carer that might be happy, or even a neighbour or a friend that would be happy to come and do that? And if they have got somebody else, please ask the patient if they would be happy to bring that person along to their appointment, so you can talk through with them, with the patient's consent, of course, how they can manage that wound and share in that care. But we also need to make sure that the wound management plan that we're going to give that patient is quite simple. We don't want to be giving patients that are having their wounds packed, for example. We probably wouldn't deem that patient for self-care. But if you've got a wound that is healing, you've got no concerns about it, there is no reason why we can't set a simple wound management plan for that patient to be able to follow. You need to provide them with instructions about washing their hands and making sure that the dressing change is as clean as possible. But you also need to educate them around the signs for infection and the signs that we need those patients to be looking out for. And also that if they do notice any of them signs, they need to be coming back in to see us to make sure that we can manage that appropriately. So we're coming towards the end of this webinar now. And just to summarise what we've talked about today, wound assessment is a very complex process. It's not simple, but we can make it simple by following assessment plans, the triangle of wound assessment. They can really help you to structure your approach to wound assessment. But also, it's a very simple step to follow, and it's easy to remember. So the patient consultation is really key to assessment, and you really need to involve your patient with their assessments. You need to be talking to that patient. You need to be looking at that patient. You need to be using all of your senses. So look, listen and feel, but also use your sense of smell too. The skin needs to be assessed from head to toe to identify any vulnerable areas that there may be, any trauma or wounds, and make sure that they are all recorded in the patient's notes. But we also need to make sure that we are highlighting those wounds that don't show signs of healing within 2 weeks. And we need to be doing those reassessments to identify any barriers to healing. So it is a very complex process, wound healing, wound management, but we can make it more simple. And by following a structured approach, that simplifying of wound management will make your lives much easier, but it will also be much better for the patient. So that is the end of our webinar. We have got our next Prepare to Heal webinars in February. So in February, on the 8th of February, again at lunchtime, and the 22nd of February in the evening, we're going to talk about wound preparation and how to prepare wounds, and how preparing wounds can help us remove the barriers to healing and progress that wound forwards. And then also in March, we're going to look at treatment. So we've already looked at the assessment. We're then going to look at our preparation, and then we're going to look at our treatment and how we can simplify treatment regimes to make, again, life easier for both you and your patients. So I hope that you've enjoyed today's webinar, and you will join us again for Prepare to Heal webinar for wound preparation in February, and again in March for treatment. Is there any questions, Janice or Ellen? So they've all been answered as we go along.
Yeah. Hi, Charlie.
Yeah.
You okay?
Yes, thank you.
Really interesting session. Thank you so much. I'm sure people have got a huge amount out of the presentation. Most of the comments that are coming through are saying that it was an excellent presentation, really educational, and also asking about the next sessions that are coming up. So it's really good that you've got this slide on as the last bit of the presentation. And we've also popped the link to the Prepare to Heal section of Coloplast Professional website in the chat box, so
Excellent.
people will be able to access it there. So thanks very much.
Thank you. Thank you all for joining. I'll see you in February.